Good morning. I'm going to start by thanking the National Academies and the study sponsor for highlighting this important issue and for giving me and our group a chance to talk about some work we've done. What I intend to do over the next 10 minutes is share three distinct ideas, hopefully quite connected, which may provide some ideas and inputs for thinking about solutions for the medical product shortages work that this workshop intends to find solutions for. So the first thing I want to talk about is oftentimes in looking at medical product shortages, we talk about logistics and supply chain and transport, but synchronized financing, the availability of money at the right time, is one of the most important and critical things for the rest of the system to flow synchronously and well. And I'm sharing results from some modeling work we did. So for a lot of developing countries, their medicines for HIV, AIDS, TB, and malaria are financed by the Global Fund to fight AIDS, TB, and malaria. And from the period 2002 to 2013, we looked at national stockouts. So these are not necessarily stockouts that are occurring at a health clinic or a hospital, but at a national level. And we asked the question, can we understand better what causes these stockouts and what are the levers, especially around financing, which can change that? And so the first thing we did was we did a econometric analysis to look at what was the inter-arrival time between two subsequent disbursements of money to the country to purchase the drugs. And this is not just relevant in contexts where the money comes from an external source. This is also relevant when money for purchasing medical products has to flow from the finance ministry or treasury or a budgeting authority to the National Procurement Agency, which then uses that money to buy medical products. So we looked at procurement lead time and disbursement inter-arrival time and used that to build a simulation model which helped us predict when, or helped us predict the risk of a stockout of medical products in a country. And when we used the model to test multiple interventions which were being talked about as policy interventions, they included things such as holding a buffer stock, holding cash buffers, or trying things such as synchronizing or essentially linking the disbursement and financing much more closely to how the inventory patterns were evolving. And what we found was irrespective of the type of the grant, which means there were some which were getting a 90-day, some were getting a 180-day disbursement, irrespective of the type of that arrangement that was used, the synchronization of financing is something that leads to the most significant reduction in probability of a national level stock out of medical products. So it's not always easy to achieve synchronized financing, but I think linking how money flows and how eventually inventory levels will deplete in a country helps reduce national level stock out significantly. And this work has led to changes in how financing disbursement flow is carried out at the Global Fund, but also in many other agencies. And I think the idea of keeping either financial buffers when you cannot synchronize financing or synchronizing financing is gaining ground as a means to reduce national level stockouts. So this was in not a disaster setting, but this was in a setting where it's routine purchasing of medical products and where stockouts were prevalent. The second thing I want to mention is liquidity gap and how poor fund flow velocity also becomes the bottleneck in pandemics and emergency settings. And when disaster strikes, the government in a region, and the region could be a state, a country, or a region consisting of multiple countries, the government does not have liquidity. So it's not always a problem about the quantum of money that will eventually be available. It's about the timing of the money. And when there is less liquidity, governments don't have a way to optimally allocate resources to things which could lead to a lower risk of medical product shortages. Those had suboptimal allocation of money to interventions that can reduce medical product shortages then leads to a more amplified shortage or a greater impact of the shortage or an adverse impact of the shortage. So insurance and financial innovation can resolve some of these liquidity challenges. There are new efforts which we've seen, such as the Caribbean Catastrophic Risk Insurance Facility, which provides parametric sovereign insurance to countries in the region, the Africa Risk Capacity Organization, and the World Bank's new Pandemic Emergency Financing Facility. Many of these were discussed at the Global Health Risk Framework study, which the National Academies conducted 2 years ago, especially in the pandemic financing and the financing innovation subcomponent of that risk framework. We also wrote about this and highlighted one additional idea, which is what is the incentive for national governments to invest in preparedness? And one way to enhance that incentive would be when a country reaches out to sovereign capital markets to raise sovereign bonds. The risk assessment agencies assess the risk on many types of risks, but not necessarily incorporate risks related to health system preparedness. And if they were to include health system preparedness risks into their risk calculation, then suddenly there is a much larger incentive for the finance minister, the treasury function, to start allocating more resources to preparedness, because that will change the interest rate at which they can borrow from international capital markets. So a lot is starting to happen in the field of financial innovation for addressing risks related to medical products. However, we don't see as strong a collaboration between the groups which are looking at supply, purchasing, distribution, and the groups who are designing the financial innovation instruments. And our ask here is, if there is a stronger collaboration, we can then leverage the monies that will become available quicker to mitigate, prevent, or resolve medical product shortages, because otherwise there are many asks for the money that becomes available through these financial instruments. The next thing I want to talk about is upstream supply chain mapping. So when we look at medical product shortages, most agencies globally tend to focus too much on finished products and think about what resilience do we have in finished product manufacturing. And what we often realize is resilience in the supply system needs to be at all levels, and in fact, more importantly, at the upstream levels, such as in the case of pharmaceutical manufacturing at the active pharmaceutical ingredient level. And oftentimes we see a strong concentration of manufacturing at the API level in one API manufacturer, which then sells to multiple finished product manufacturers. So if you only evaluate the system from the lenses of how many manufacturers there are, what is the risk of a manufacturer going out of supply, it may seem like all is well. But then they may all be buying from the same API supplier, who in most cases is located in India, China, or overseas manufacturing territories. And that risk is not always fully understood. So we carried out a multi-year study to map and understand the market structure and supply linkages and supply capacity at the active ingredient level. So essentially understanding which finished product manufacturer purchases from which API supplier, what is the capacity of that API supplier, and how many such API suppliers are there at that level for a given therapeutic category. And what that enabled is for people to understand that risks sometimes were more upstream and start thinking about ways to increase resilience at that level in the manufacturing chain. And this is an activity which was funded by UNITAID, but a key takeaway from this was not only for the products that we were looking at or the therapeutic areas that we were looking at, we found that such information is either very weak or opaque for almost all categories of medical products. And some of this can be obtained with public data sets, and some of this requires primary research, but an effort which combines public data sets and some primary research to look at supply linkages, capacity, and the number of manufacturers is an important prerequisite to thinking about resilience in the medical product supply chain. And then the last thing I want to talk about is the role of information. And this is, again, work which looks at how can we leverage better information for collaborative supply chain planning, and how can that lead to reduced national stockouts of medical products. So in many of the countries we work in, there are a large number of stakeholders, financiers, multiple manufacturers, country purchasers, supply chain service providers. And each of them has a different demand forecast they are working with, and also at times slightly different opinions about what future demand would look like. And national supply chain managers, so people who are managing the purchasing and distribution function for the government-run medical supply system in a country, have very limited information about what is coming as inbound shipments to them. And despite trying, inbound visibility has remained weak for a variety of reasons. Some are technology related, some are people and process related. And as a result of this, suppliers also have very limited visibility into both what is coming into their order pipeline in the medium term and what is the long-term forecast like. So they cannot do their planning well. And as a result, oftentimes they operate in a mode where they wait till a confirmed purchase order comes to them and then start manufacturing, and cannot do much based on forecast. So one idea is a visibility and analytics network, WAN in short, which brings together people, process, technology, and policy, and helps them collaborate to build a more demand-driven supply chain planning process. It pulls data from multiple sources into a format which can guide the best decisions. And the benefits then are that the national supply chain managers get full visibility of what is coming their way, so inbound visibility. The financiers get a coordinated view so that they can engage in collaborative supply chain planning. And then the manufacturers have information to plan better both their batch sizes and campaigns. And this is work that the Bill and Melinda Gates Foundation has started piloting in a few areas of our work. And our hope is that a similar structure can evolve, which enables better information sharing between multiple stakeholders and can then lead to better collaborative supply planning. And we have a lot of studies and evidence shows that a structure like this reduces national stockout risks and also helps manufacturers do more proactive planning. So we hope that something like this can be put in place, especially for those medical products where overall supply is limited and the risk of a shortage is high and the impact of a shortage is significant. So a system which can bring together different stakeholders for collaborative planning can help in that regard. I'll pause there. Thank you.